All right, folks, welcome back to another Technical Thursday. We're going to talk about the grey dog here, depression. And we're going to get a little bit technical on the role of position and respiratory influence on depression and subcircadian rhythm or ultradian rhythm. So I know it sounds complicated already. We're going to go through some of the ways poor respiratory patterns affect us from a chemical and mechanical perspective. And then we'll go through the actual mechanics of it itself. So, number one thing to say here is depression itself. This is not I feel sad because I had a bad day today. This is typically a chronic state. I am in no way undermining the impact of depression. I have a familial history of depression, including my brother committing suicide from his bipolar depression. So I'm not trying to minimize it whatsoever, but nor am I trying to say, by the way, that is a solely physiological phenomenon. Very obviously, it is also a psychological phenomenon. There are multiple factors at play here. However, it's very well documented that there are psychological factors in depression. I'm going to address what we can address or what you can address if you suffer from depression from a physiological perspective, and not just the very general throwaway advice of do more exercise, because that's not necessarily helpful, particularly if the exercise is causing deleterious or detrimental effects on us from a respiratory and positional patterning aspect. My God, it sounds technical and annoying already, but I promise I'll try to keep it simple and we'll break it down to kind of like positional stuff later. So again, number one, I'm not saying physiological positions and physiological considerations are the only thing that matter with depression, but they are a significant factor that is undertreated and often ignored. So, and we'll define poor respiratory patterns and optimal respiratory patterns-ish a little more later. But let's talk about poor respiratory patterns. When we have people who overbreathe, which is a lot of people, if you're someone with flared ribs, big rib cage, the bottom of your ribs goes out here like this, you more than likely have a respiratory issue, okay? When we have that, we typically get higher oxygen uptake, lower CO2 uptake, which, there's this idea that oxygen is good and carbon dioxide isn't. It's not necessarily true. In this particular perspective, CO2 pretty much acts as a vasodilator in cerebral circulation, so it's going to actually help us get more blood flow in and around the brain. When we get that vasoconstriction or the lack of CO2, lack of carbon dioxide in the brain, it can actually lead to reduced oxygen delivery to cerebral tissue, to brain tissue. So it can lead to reduced cognitive function or emotional cognitive function. Now, on top of that, lower CO2 tolerance is a risk. And it's a risk as perceived by the body and the system. And this is important. I know stuff is not super sexy or super exciting, but please bear with me for a couple of minutes if you care about any of this stuff. So the thing called the Bohr effect, B-O-H-R. Niels Bohr, who came up with the electron orbit theory, if you remember high school chemistry, I believe his brother figured out that there's a particular pH range at which red blood cells or hemoglobin allow oxygen to be delivered to the tissue. If the pH goes above that or significantly below that, we won't get the oxygen leaving the red blood cell. So you go to the doctor, they put the pulse oximeter on, and your SpO2, your O2 saturation, will be high, 98, 99%, and they'll go, okay, no O2 problems, no oxygen problems. But it may be that you have circulating oxygen that you can't actually use at a local level. Now, that will influence local perceived pain, muscular pain, joint pain, etc., pretty significantly. The literature is very clear. But it will also give us a nervous system cascade of cortisol, the stress hormone, that we don't really get out of. It's like being a low-level fight or flight response the entire time, because even though we're breathing in potentially a large volume of air or with high frequency, we have low available oxygen, low available air at local tissue level, muscular level, brain level, etc. Okay? This is why I talk so much about breathing, because breathing is the underpinning aspect with which we can then leverage to benefit other things. We're going to breathe 18 to 23,000 times a day. It is the biggest single factor that we can control and repattern to make everything else work better. Okay. On top of that, depression is constantly, and again, well-documented associations in literature between reduced parasympathetic activity and higher sympathetic activity. Our sympathetic activity is our fight or flight. Our parasympathetic is our rest and digest, if we're trying to oversimplify things just a little bit. When we have a sympathetic dominance, we typically have what I just talked about, that overarching kind of high levels of cortisol and underutilization of carbon dioxide. I promise it's going to get less boring in a minute when I get to the practical part. It's, again, well documented that appropriate breathing work can change autonomic balance and get us more towards rest and digest. So that this is the important part, guys. I don't want everyone to have to think about every single breath they take, But if we appropriately motor pattern people, they will feel better at rest by default. And this is what we're looking for. We're not looking for acute strategies to make someone feel a little bit better right now. That's still helpful, by the way. Acute strategies are great. But having a strategy we can use to make yourself feel better first thing in the morning and last thing at night by doing nothing that day is the ideal. So we want to build up to that with a structured incremental strategy of motor learning. Okay. Heart rate variability and emotional regulation, both those again associated with depression and impaired stress resilience. If you have low HRV, which is the intra-beat time distance, and very obviously emotional dysregulation, depression are highly correlated. But breathing patterns, again, both of these have been associated in literature very, very well. Mechanical respiration and posture. I have a little handout for this. That's why if you see me scrolling over here, this is something I say to clients occasionally. The diaphragm functions as both a respiratory and a sensory organ. Poor posture, and everyone thinks this is good posture, chest up, shoulders back. That's great posture if you want respiratory problems. That is not good posture for living. It is not good posture for sports. It is not good posture for almost anything to be stuck there. It is not a problem if it's a transient position we pass through. If you're jumping, for example, you have to get the chest to come up, the shoulders to come back like this. Very appropriate, but not when you're landing. Try to land like that and enjoy the pain you're going to have in your knees, joints, and low back, because you'll have it real soon if you try to keep that position. When we have those ribs flared like this, we're going to have decreased diaphragmatic excursion, i.e. diaphragm won't drop down. If the diaphragm won't drop down, we have two choices. Either don't breathe anymore, which is very much our short-term play, or if we can't drop a diaphragm down, because there should be two little domes here like this, kind of like a McDonald's arch situation. Basically, when the ribs flare, this gets stretched out and can no longer drop down. So if we can't descend the diaphragm, we're going to try to descend it by proxy. And what I mean by that, the diaphragm won't go down because it's long. We'll lift the rib cage up instead. So if you're someone who, when you take a big inhale, everything comes up like this, you see neck muscle tone increase. If you always have very visible SCMs and upper traps, very likely I'm talking about you. With the increase in cortisol, the stress hormone, again, cortisol is not bad. We should have an up and down rhythm to our cortisol with our ultradian rhythm, which I'll get to in a minute. But that up and down with cortisol is also, if it doesn't go down, we have increased inflammatory signaling, again, which is going to give us fatigue, mood disruption, emotional dysregulation. I promise it's not all doom and gloom. We're going to talk about how to fix this as well. There's a lot to really talk about this. It becomes a feed-forward pattern is the problem. When we have this inhalatory pattern, we breathe in more. And by the way, if you take it to its extreme, it can be a panic attack. It's literally we're breathing in so much that we feel like we don't have any air left. So what we do is we breathe in more and more and more. And then we have less and less oxygen available, paradoxically, because the pH comes up. How people will typically ameliorate this in the short term is they'll breathe into a paper bag and recirculate lower oxygen air, higher CO2 air, and tends to bring them down. What we want to do is we want to teach you how to, use that paper bag technique without the paper bag to regulate yourself all the time instead. By the way, you don't have to be depressed for this stuff to work. This stuff works if you're a little bit anxious, if you're a little bit fatigued, if you're a little bit, feel like you're just not yourself the way you should be. Especially those of us who are in 30s, 40s, 50s. That kind of feeling of like, oh, I'm fatigued, things suck. And especially in the current political and, geopolitical climate, it's nice to be able to just relax and actually just tune everything out and let the stress go for a minute. In terms of limitations of breathing interventions, there's a lot of misinformation about breathing, which I'm hoping to kind of get rid of some of that today. It needs to be pretty specific and kind of pedantic to really work well. And when we do that, we need to then integrate that same type of positional breathing work into other things that we do. For example, if you go and do phenomenal breathing work, and then you go off and do everything with an arch back in the gym, that stimulus is likely going to be too strong and it's going to overcome that. There's no reason whatsoever we can't, with biomechanical correct form, start to integrate the same movement principles that we do with the breathing into weightlifting. And I have lots of videos on that. Most of them are private though, mostly for my members and clients. But there's some examples on my Instagram as well, other social media. Again, just want to touch base before we go into the mechanics on this stuff that I'm not saying breathing is a cure-all for depression and psychological disorders at all. What I am saying is most of the literature, most of the contemporary literature on SSRIs, selective serotonin reuptake inhibitors, which are the most, as far as I'm aware, this is not my area of expertise, but as far as I'm aware, they are the most often prescribed antidepressants. They are no more effective than a placebo and have a lot of drawbacks. This is a relatively low risk strategy we can use with breathing. If someone has other non-physiological contributors, they may have to also have a psychiatric or psychological consult as well. Go to therapy. Fucking talk about stuff, guys. Don't just stew in your unhappiness. Okay, great. Let's move on to the actual mechanics of this stuff. And I cannot stress enough. This is not okay, do one set of breathing exercises and that's it. Now I'm done for the rest of my life. This stuff needs to be progressed, okay? The two main criteria we want to fulfill when we're teaching someone anything, whether it's a movement thing, whether it's teaching them a language, teaching them a skill, teaching them something professional, doesn't make a difference. We want to be in a learning environment of safety. When it comes to movement stuff, that means the brain and body have to predict safety. That means we want to have a lot of information from the ground, so you start off on our back in simple breathing positions. We are not looking for belly breathing. I have a whole video, you can find it on my Instagram. It's a VR video about why belly breathing is not good. It's not what we're looking for. I'm not going to get directly into those mechanics, but I do want to talk a little bit about ultradian rhythm. Anyone watching this video, if you're a little bit clued in at health, you probably know what circadian rhythm is, our 24-hour clock. My good friend, Dr. Alexis Cowan, does a lot of phenomenal work on circadian rhythm. Go to her page. She talks about it a lot, about light exposure, UV light, NIR light, etc. It's like, go there. She covers all that. We're going to talk a little bit about ultradian rhythm. Ultradian rhythm is your subcircadian rhythm. It is the swap over between paranasal sinus dominance, which should happen every 90 minutes to 4 hours. Your paranasal sinus. You know the way your nostril swaps over during the day? I know we're getting pretty technical here, guys, but this is important. When the nostril swaps over every 90 minutes to 4 hours, depending on the individual, it should at least, that is a swap over between being sympathetic and parasympathetic. We should have this wave function throughout the day where we're aroused, excited, upregulated, and then we're not depressed, but we're down, we're rest and digest. And we should be going up and down, up and down, up and down. If we can't create apparently I can't speak today. If we can't create pressure differentials in our cranium, in our skull, in our meat balloon, in our head, then we likely can't swap over the nostrils and swap between being sympathetic and being parasympathetic, okay? If you're someone who has necks that are constantly breathing for us, pulling on the cranial bones 18 to 23,000 times a day, it's likely we're going to have relatively immobile cranial bones. If you're watching this and you're thinking to yourself, well, cranial bones don't move, skulls don't move, I encourage you to please read any literature from the last 20 years talking about this subject, because you're a dinosaur if you're a professional. If you're non-professional, it's not your fault you don't know that. We have spongy bone at the sutures of the skull called cancellous bone that allows a couple of degrees of motion. If you don't want to go to all the trouble of doing that, Google slow motion boxing uppercut or something. You'll see someone's whole skull deform, not just their jaw. You'll see the skull rotate and change and then shape back. Okay? Skulls move. That's not a question. If you're kind of sitting here crossing your arms and huffing puffing watching this video and you're a professional, please go and rethink your approach. If you're not a professional, ignore that whole rant. That's just me being angry at having to deal with this all the time. So, when we have this paranasal sinus swap over, there are a couple of prerequisites we need to have it. We need to be able to have cranial bones that can rotate. We have big flat bones in our hips called the innominate bones. These big bad boys here. Okay? These big flat guys. We have them in our upper body, which would be our shoulder blades, our scapulae, which sit here and here like this. Obviously, they're not on this particular skeleton. And we have big flat bones in our head, called temporal bones. They all work relatively parallel to one another. When we have inappropriate respiratory patterns, and again, I know, guys, this is not sexy. I know it's not sexy, but this is important. I need you guys to know that you can't just do a couple of breathing exercises, completely ignore your position, go do some dumb shit in the gym, and expect everything to get better. It needs to be a systematic, planned, integrated, and incremental change if you want to have long-term change. If you want to do some dumb stretch, foam rolling, and mobility work, I'm not saying those things are always dumb, but those are acute tools for acute problems. You can't use an acute tool for a long-term problem. Okay, that should not be. It's like using a kitchen towel to dam a river. It's a short-term small job tool, right? It's for a small leak. It's for a small spill. It's not for stopping it down. Okay, that's the equivalent of trying to use a stretch to fix a chronic movement selection issue. It drives me insane. People are like, I've been stretching for 10 years. That's what I'd like to do. I'm like, great. Have you got more flexible? No. Has it solved any of your pain? No. I'm like, great. Then why are you married to it? I know I'm just ranting into the void right now. So when we do the respiratory work, what we really want to learn how to do is what we call posterior mediastinal expansion. And we're going to have to do a lot of things. We're going to have to learn how to tilt the pelvis. And it's not very popular in the fitness industry. People love to say anterior pelvic tilt isn't a problem. Here's the reality of it. It's not a problem for some people. Some people, but getting there is not a problem. It's only if you're stuck there, it's a problem. Okay? If you don't have options, i.e. you can't swap over, that's a problem. If you don't have options in your pelvis, you cannot have options in your cranium. That's not a question. The mechanistic explanation is long and detailed, but just trust me on that one. If we have that anterior pelvic tilt, there's a lot of people, those flared ribs, these are just signs. If we're always in those positions, we're not descending a diaphragm, which means we can never have appropriate paranasal sinus swap over, which means we can never appropriately swap between rest and digest and fight or flight. Very, very often when I do respiratory work with people, they go, after just one, it takes a long time to cue the first exercise, but when I work with people, they'll go, oh, I feel so relaxed after just doing about 2 to 3 minutes of work once they've cued it all together. And they don't understand why. We're teaching them how to regulate the nervous system first and foremost. The brain likes safety. In the absence of safety, the brain will just look to keep you alive. That's all. So when we talk about these movement patterns and talk about anterior pelvic tilt, it's very often framed as not a problem. It is a problem for the vast majority of people if they're stuck there. There's a certain small percentage of people who really aren't going to experience or perhaps perceive the symptoms that they have, the lack of mobility they have. And these people tend to be the ones who are just resilient across the board anyway. They're just hard to break. If you're not those people, if you're a normal human being who's not easy to break, but you're a little bit less automatically resilient, either genetically or through environment, then this stuff can be really helpful. Learning how to tuck the pelvis, not to keep it there all the time, because we still want things to alternate. We want to go back and want to go forward when we walk and do most athletic activities, will allow us, once we can tuck the pelvis, the ribs will drop back and down. And I'm not saying hunch, they will drop back and down, and allow the diaphragm to drop down when we inhale. We don't want distension. If I have a belly breath here, it starts to roll the pelvis forward. Any of you guys with low back pain, I know quite a few of you watching will, L4, L5, S1 are getting compressed here. I'm not saying that's the only reason for injury there, but it's certainly a contributing factor. And if we don't address, again, the stimulus that's happening 18 to 23,000 times a day, we cannot expect long-term change. That doesn't mean we want to try and consciously do the breath all the time. How motor learning is going to happen, we have 2 major criteria to fulfill. I need your brain, not you intellectually, your brain, different things, to predict it to be safe and efficient. That's only going to happen with practice. We're going to practice in a safe context and gradually, incrementally, and systematically increase the context, difficulty, speed, velocity, load, all that stuff, until your brain is comfortable doing this during high-level tasks, including weightlifting and sports. I do this with PGA players, I do this with professional golfers, I do this with professional fighters, I do this with random grandmas who want to learn how to walk better who are currently in pain. This stuff works, but it does take a couple of weeks to get started. So, rant again, I know. So when we have this anterior pelvic tilt, these like this, boop, the ribs are going to flare. I'm obviously exaggerating a little bit like this. You guys can see how a diaphragm would get long. If the diaphragm lives in here, like this, it's this dome, right? It's attached to both sides here. If this stretches out, the diaphragm has to also stretch with it, so it can no longer descend. So now it has to ascend. If when you inhale, this is happening, this is you. You need to learn to breathe better. That's usually going to take 10 to 12 minutes of work once a day. Couple of weeks you progress, couple of weeks you progress, couple of weeks you progress. That is the link between respiratory patterning and depression, emotional cognitive disruption. It is because we cannot, not the only reason, low local oxygen availability, sense threat, high cortisol, and an inability to swap over paranasal sinuses. And we're not going to get into the exact mechanism of all of those things. I have literature on all of those things, by the way. But I just wanted to cover the basic topics there. There is a relationship and it can be dealt with. It's not going to be a one and done. No one can come in and put you in position. I'm talking about chiropractic, I'm talking about physical therapists, I'm talking about massage therapists. No one can come in and put you in a position that's going to last for a long time for a chronic problem. A chronic problem is because the brain is selecting a motor pattern that is not giving you the appropriate outcome. It's like if I said to you, I want you to learn piano. You don't play piano. I'm going to grab your hands and play the music. Obviously, I do not play piano either. I do not have piano hands. But I'm going to grab your hands and play the music. So that's the same thing as getting manual therapy. It's someone else doing it for you. If I don't then teach you how to play, but ask you to perform, you're going to fail miserably in the performance. That's the equivalent of using massage, physical therapy, foam rolling, etc., to go and do long-term change stuff. They are absolutely appropriate tools for acute problems. They're great for that. For a chronic long-term issue, they are not the tool. You need to repattern and make more movement options and more strategies available to the brain so the brain can choose the best available option. There's another thing that went around the fitness industry a while back, which I'm just going to cover real quick. Self-organization. Oh, we don't have to worry too much about form because the brain will self-organize. That is so dumb, it hurts my brain. Self-organization will happen based on predicted available movement patterns. If you haven't learned to do something in a low-stress, simple environment, the chance of you doing it when you're highly stressed, i.e. under a heavy weight or at heavy speed or in a high-skill, very quick situation is zero. Absolutely zero. Just because your brain intellectually knows how to do it doesn't mean kinesthetically it will. Okay? It has to be perceived to be the most efficient strategy, which takes practice like anything else. Unfortunately, there are no shortcuts to being good at anything. The bright side is I've worked with a lot of people on exactly this, and this is related to increased sports performance, increased power output, decreased injury, decreased pain, even when we have an absence of significant tissue trauma. A big predictor of local muscle tissue pain is low oxygen. Low oxygen can be from what we talked about earlier, that Bohr effect, or from a chronic occlusal pattern, i.e. the muscle's always on, never turns off, because the brain doesn't have an option. That usually starts with poor respiration. Even when we talk about distal issues, when we talk about knees and ankles, if we don't address central positioning, we can't affect distal positioning. Anyway, before I dive down 15 other wormholes of conversation about this, the main topic today that you should have really kind of got your head around is there is a relationship between the nervous system and respiration, between emotional regulation and cognitive regulation and respiration. If you took that away from this video, you took the right thing away from this video. And the last thing you take away from this video is if you leave me unchecked, I would just rant about everything because I'm a grumpy old man. But that's not changing.